All right. Good morning, everyone, and thank you for joining us again for another great session of Global Neuroscience Institute's Grand Rounds. It gives me great pleasure to introduce today's guest speaker, Dr. Ali Alaraj. Dr. Alaraj is an attending neurosurgeon at the University of Illinois Health and a tenured full professor of neurological surgery at the College of Medicine at the University of Illinois. Dr. Alaraj is dual trained in open vascular and endovascular neurosurgery. He is an elected admission to the Alpha Omega Alpha Honor Medical Society and the Sigma Xi, the Scientific Research Honor Society. His clinical practice includes treating patients with ischemic and hemorrhagic strokes. His medical expertise includes neurocritical care, treating patients with brain aneurysms, arteriovenous malformations, complex dural-arteriovenous fistulas, carotid cavernous fistulas, carotid arteries, and intracranial vessel stenosis. He is currently the medical director of the Neurosurgery Intensive Care Unit, the co-chair of the Comprehensive Stroke Program at the University of Illinois Health, and the director of the clinical operations at the Department of Neurosurgery at the University of Illinois Chicago. He has more than 260 published peer-reviewed articles and textbook chapters. He also serves as the editor-in-chief for neurological research. He sits on the editorial board of Neurosurgery, Interventional Radiology, and other journals. His research interests include outcomes of management of brain aneurysms and arteriovenous malformations, quantitative cerebral flow measures, computational quantification of intracranial flows by angiography, and virtual reality simulation in neurosurgical training. Dr. Alaraj, thank you for joining us this morning, and we look forward to your presentation.
Thank you very much. It's a great pleasure being with you this morning. I really appreciate the invitation and looking forward for a very pleasant discussion later on. So today I will be presenting about arteriovenous malformation, but in specifically focusing more on the role of blood flow and hemodynamic stresses. So what is the outline of my presentation? A little bit of discussion about the natural history. Second is how we quantitate the blood flow in AVMs. What is the relationship of the blood flow and microhemorrhages? What is the role of embolization with respect to the blood flow? And what's the relationship between hemodynamic stresses and flow-related aneurysm, and then hemodynamic stresses and the venous stenosis and the role of inflammation. So some going back a little bit into the basics of the pathophysiology of arteriovenous malformation. We're going to get started by talking a little bit about the old paper, which is the proposed model for grading for arteriovenous malformations from Spetzler, and that goes back into the 80s. And the take-home message from this slide is that as the grade increases, the surgical complication increases. And if you look at the minor deficit, major deficit, it kind of increases gradually. And when you talk about grade 3, grade 4, you're talking about a deficit between minor and major in the range of in the teens, late teens, or in the 20s. So that is the take-home message. That is the surgical outcome back about 30 or 40 years ago. So how do we do recently? How did we progress during that period of time? So the natural history of arteriovenous malformation is affected by multiple variables. One of them is if we have prior hemorrhage, if we have deep location, extensive deep venous drainage, associated aneurysm, cerebral dislocation, and venous stenosis. All of those things increases the risk of AVM rupture in the future. We do have some recent data that came from Aruba trial that we all have our own critique about it. But in the Aruba trial, whatever has been treated, and they used multiple ways. Majority includes embolization, some partial embolization, combination with radiosurgery or alone. 5 patients only had surgery. But if you select that approach, you end up with the worst natural history. And the hazard ratio becomes, almost 0.3 than the natural history. So it's actually the opposite. The treatment makes the natural history much worse than observation alone. So it's clearly that we're going to need to have a little bit more understanding about how to address those things. You can see that the natural history picks up immediately after the treatment in the first few months. So it clearly has to do with our treatment, where we have done either a complication or a change in the natural history of the bleeding. That resulted in a decrease in the number of patients that have been treated. So Aruba did have impact our patients, and more patients with bleeding starts presenting to us. So what differentiate AVMs from brain tumors, anything else? Why do we treat those things any different? And is it that the higher blood flow within the nidus is blood flow a matter that affects AVMs rupture, presentations, all of that stuff? So this is an illustration to show you that the map in the middle is what we call the quantitative magnetic resonance angiography flow map. And on the left hemisphere, on the right hemisphere, the right MCA is 303 cc's per minute. The left MCA is 91 cc's per minute. And all what you need to know is that both hemispheres should have the symmetrical blood flow. So this patient have an exceedingly high blood flow on the right side because there's a right frontal AVM that actually supplied by the right MCA. We can measure the blood flow on the draining veins. If we have a large draining veins, an example on the right side, you can see the cut on the vein. And from that, you can quantitate also the wall shear stress, which is the average cross-sectional wall shear stress on the artery. And that kind of helps us understand some of the pathophysiology that we're going to be talking about later on. So you get a flow map that looks like this. In this particular patient, the flow in the draining vein, one of the draining veins, is 700 cc's per minute. And for comparison only, we need to remember that the carotid artery normally is in the range of about 200 cc's per minute. So this AVM has at least 3.5 times the normal blood flow that runs in the carotid artery. So you have an estimate about what you can encounter when you deal with this during the surgery. And we said out of that, we can calculate the average wall shear stress because we have the flow and we have the radius, so we can come up with that calculation. So the first question that we need to ask, is the higher amount of blood flow a risk factor for AVM hemorrhage itself? So because now we can quantitate the blood flow, can we really understand the relationship to bleeding? So this is just to demonstrate that you could measure the blood flow, you can measure the velocity by this quantitative MRA in the feeder vessels and on the contralateral sides. We do know that the feeder vessels have a higher amount of blood flow, but we can now quantitate that. So we can have a number that can follow on. So when we looked at some patients that presented to us with AVM and looked at their angiographic angioarchitectural features, you can see that patients who have intranidal fistulas have almost double the amount of blood flow compared to patients who did not have an intranidal fistula. And that is something that also is understandable because the intranidal fistula creates a low resistance within the nidus and pretty much faster shunting between the arterial and the venous system. So the intranidal fistula by itself is a driving force for a much higher amount of blood flow. And also the venous ectasia has much higher amount of blood flow as compared to patients who did not have venous ectasia. And the reason for that, because when you subject the veins for a very high amount of blood flow, that will result in venous ectasia. So intranidal fistula is a driving force for the higher amount of blood flow, and the venous ectasia is a secondary mechanism for the higher amount of blood flow. So now we can put a number on that so that we can compare between different AVMs and we can evaluate that a little bit better. So this is one of our previous studies that we looked at the patients who presented with seizures, with hemorrhage, or incidental. But you can see that the patient who presented with hemorrhages are much smaller than the one presented with seizure. So 5.4 cc's compared to 14 cc's. But also you can see that the amount of blood flow that is within those AVMs, it's much less than the patient who presented with seizure. So it does not seem that the higher amount of blood flow means that the higher risk of bleeding. It might be that blood flow and volume are related to each other. So the higher the volume of the AVM, maybe the higher amount of blood flow in general. And when you divide the blood flow per volume of the AVM, you come with something what we call the flow index. And you can see the flow index is a little bit comparable between the two, meaning that within each cc of the nidus, you have a comparable amount of blood flow that runs in there. The standard deviation is large, which means that you're going to have patients that are a little bit off to this side or to that side of the curve. This is more updated table, and this is a much larger sample, and you can see that patients with bleeding did have a lower amount of blood flow as compared to one that did not have bleeding. So if we look at uh, uh, yeah, so this is just to kind of compare the flow index, and you can see that the flow index is not different between patients who have fistulas or ectasia, which means that the flow also might be distributing within the nidus itself. There's multiple ways that you can look at the blood flows. There is the semi-quantitative way, which is the DSA Q, which some people are using as a way to indirectly correlate with the blood flow. There's multiple sequences with the MRI. The thing that we are using is the quantitative MRI. So when we established that it doesn't seem that the higher amount of blood flow increases the risk of bleeding from the AVMs. But is there a relationship with what's called the microhemorrhage within the AVM and the higher amount of blood flow? So microhemorrhage is a new concept that has been introduced recently, which is the silent asymptomatic presentation. You find some signal change on the gradient echo or in the susceptibility weighted images that suggest that this patient might have a micro or silent bleed. And presumably, there is supposedly a higher rate of future hemorrhage in some of these studies that came up recently. This is 6 different patients that shows you how a microhemorrhage would look on the gradient echo. You can see there is a small kind of subtle black signal around the nidus, and the patient did not have any clinical hemorrhages in the past. So we did look at patients who have microhemorrhages and patients who did not have microhemorrhages, and we looked at the different variables. But what you can see here at the bottom of this slide is that the blood flow, it seems, is higher in patients who have microhemorrhages. So that might be suggestive that this microhemorrhage mechanism that is occurring within the nidus might be secondary to higher amount of blood flow. So it might be that there will be a relationship between the two that we have not known in the past. So when you look at the multivariate analysis, the higher amount of blood flow remains positive. Also, venous anomaly also remains positive in the multivariate analysis when we looked at the blood flow and the microhemorrhages. So it seems that there is some correlation between those two. So the next question that we're going to ask is there any role for inflammation within the nidus itself? So we looked at the resected niduses. These are not being embolized in the past. These are AVMs without embolization, so there's no inflammation from embolization. We stain them with CD68s. We look at macrophages and HE stain to look at other stuff. And then we counted the number of the stained nuclei in there, and we have a grade that we use for hemosiderin as well. So the question here is there a role for inflammation with respect to the amount of blood flow? And you could see here in this slide is that clearly that the CD68 count, which is the macrophages, the evidence of inflammation, is higher if you have some microhemorrhages within the nidus or hemorrhages within the nidus. And you can see that there's some correlation between the CD68 and hemosiderin grade. So what does that mean? It means that if you have inflammation and you have bleeding, there is some association between the two. But which one might be the cause? We cannot answer that from this particular experiment. But we know that these two things are going hand in hand. So we've kind of talked about the blood flow within the AVM. Next question is that what dictates the blood flow? Why there's AVM that has a high blood flow? Some AVMs, excuse me, with low amount of blood flows. And we look at the resected AVMs, and you can see here in the slide, this is a cross-section of a draining vein within the nidus itself, and the vein at the bottom is a vein that has some intimal hyperplasia. So some of those veins within the nidus himself, they do have some kind of intimal hyperplasia in them. And you could also count the number of the cross-section within the within the specimen. So you remove the specimen and you count all those cross-sectional areas of the vessels, and then you sum all of that, and that gives you the sum of the cross-sectional areas of the vessel within that specimen. If you correlate the sum of the cross-sectional areas with the flow, you end up with this type of relationship, which means that the larger the cross-sectional areas within the nidus, the higher is the blood flow. And that is indicative of the low resistance that the cross-sectional areas is mating. So the larger the cross-sectional area, the lower the resistance, and the faster the blood will shunt from the arterial to the venous phase, and you end up with a higher amount of blood flow. So it seems that, as we've kind of known before, is that the angiographic intranodal fistulas, which has the larger amount of the cross-sectional areas, is the driving force that we see on angiogram, but also on pathology. You can measure that cross-sectional areas and you can correlate that with the blood flow, which confirms the intranodal fistula is the driving force for the higher amount of blood flow. So when we talk about the role of embolization, can we look at the role of embolization in a different way? Can we look at the role of embolization in a way that we need to reduce the blood flow rather than reduce the blood volume? So can we look at that from the blood flow perspective? And these are three different examples of three AVMs. The one on the extreme left side is someone with a small nidus, but with a giant venous aneurysm. And that has about a 1200 cc's that runs there. So this is a really, really, really high amount of blood flow in that AVM. The one in the middle is supplied by the MCA, and the PCA has about maybe 600 cc's, and the one on the extreme right has about a 300 cc's if you subtract the MCA flow from that right MCA. So this is showing us that the volume of the nidus itself sometimes does not correlate with the flow, although we know in general that there's some correlation between the two, but there's some niduses who have a much higher amount of blood flow, even though they're not really very large. So volume and flow might not be synonymous in that case. So we've kind of talked about the intranodal fistulas. When you look at patients who have intranodal fistulas versus patients who did not have intranodal fistulas, there's about 100 cc's difference between the two. So it seems that if you do an angiogram and you see large artery that comes in that immediately shunts into a large vein, then you're going to need to know that there's about at least 100 cc's running into that intranodal fistula. And when you close intranodal fistulas alone, so if you do treatment and during that session you only close intranodal fistula, you drop the blood flow by about an average of 100 cc's per minute. So closing a fistula can really result in a significant amount of blood flow reduction. And if you take multiple pedicles, you end up with really small amount of that. And this is not with Onyx, this is the multiple sessions with the glue. So this is an illustration to show that we do have a spectrum of patients that have baseline blood flow that ranges all the way from 100 to almost 1,000 cc's per minute. But once we start with a higher amount of blood flow, we are doing multiple sessions of embolizations to sequentially drop the blood flow. But if we have someone with a blood flow of about a 200 or 300 cc's, probably this patient is going to end up with only one session of embolization prior to surgical resection. The blood flow is here shown by the circle on the right MCA, and you can see how the blood flow is sequentially dropping after each session from 478, 359, 216, and 173. And also, subsequently to that, the straight sinus flow dropped from 500 to 100 cc's after 4 sessions of embolization. So you can do a sequential blood flow reduction, and then you can take the patient to the operating room when you feel that the blood flow has been reduced to a level that you think will be easier for you to manipulate the AVM without an excessive amount of bleeding, swelling, and you can retract on the AVM and go around it and remove it nicely. So once we do those embolization, you can see on average how the amount of blood flow drops gradually with time. But the highest amount of blood flow reduction is during the first session. And that is mostly because we are using a flow-directed microcatheter, and we are going to the intradural fistulas, and we are closing those things at once, the first time. So this is a busy slide, but the aim of this is to compare two groups of patients. All patients have surgery. One group have pre-op embolization. Another group went for surgery without pre-op embolization. So in the blue table, you can see that the patients who had a pre-op embolization have much larger volume. And also in the green part, you can see that the patient who have pre-op embolization have a much higher amount of blood flow, 400 versus 43. But once we did the embolization going down to the orange table, you can see that the blood flow dropped from 424 down to 121 cc's per minute. So you start with a larger AVM with a higher amount of blood flow, but you drop it to 121 cc's. But then the intra-op blood loss between the two groups becomes comparable. So even if you have a very large AVM that is 6 cc's on average or above that, you end up with the same amount of blood flow as doing surgery for an AVM with a 1 cc volume. So that kind of shows you that the pre-op embolization might have a role in facilitating the surgery and reducing the blood loss. This is a patient that I did 2 sessions of embolizations for. The first session was with glue, and the glue that was injected is where the red arrow is. So that's the first session. The second session is with onyx, and you can see that with the blue arrow, the onyx cast in there. So the first session, which is the glue, resulted in maybe about a 250 or 270 cc's reduction of the blood flow because we close an intradural fistula. While when you come back and you do this volume reduction, you end up with reducing the blood flow by about 110 cc's. So this is just to illustrate that volume reduction and blood flow reduction are not the same. If you close intradural fistula, you end up with much higher amount of blood flow reduction. And if you are going to take this patient for surgery, you should probably think about the blood flow as a target for embolization rather than the volume as a target of embolization. And this is at the end of the embolization, and a lot of people will consider this as a success. But this AVM is very alive. It has 150 cc's per minute, almost the same amount of blood flow that runs in the carotid artery. So this went for surgery, definitely. So this is going back to this example where you can see that you can measure the blood flow in those draining veins. One of the draining veins have 400 cc's, one of the draining veins have 200 cc's. So really severe venous engorgement. So definitely not someone that you want to take to the operating room with that amount of blood flow. So here we embolize this sequentially with coils and then with glue. And then the patient went for surgery. This is to show the embolization itself. This is putting coils in there, but because of the higher amount of blood flow, we have a balloon that's being inflated so that we put multiple coils in that fistula. And then at the end, this is the selective injection showing the blood flow. It's still very, very high despite the coils. And then finishing that with the glue. And here, high concentration glue, 66%. And the whole reason why we're putting the coils here is just to slow the blood flow and create a basket where the glue will catch on that so that the glue does not end up being on the venous face. So inject enough glue to have a small segment where it really kind of touches the artery on both sides. And then we pull the microcatheter and the patient went for surgery. Now you can see the nidus, which is around it, and the other associated draining veins draining the rest of the nidus. So when we did that, the blood flow have dropped from almost 1200 in the MCA to 200 in the MCA. And you can see also the blood flow in the draining veins in the transverse sinus has also dropped significantly. Another example, someone who has this intradural fistula and there's a severe venous congestion in the cerebellum. You can see that there's a lot of cortical veins on the cerebellum that are extended. So this is the angiogram for this patient. And the goal here is to try to slow this, the first thing. And then after that, you can come in, you can do embolization with glue, you can do embolization with onyx, you can do whatever you want. But the first session for us in this particular case is to do that with flow reduction. This is a flow-directed microcatheter, and you can see that how it's going around the pica. That's small black dot that is moving on the screen. So we're going to get that all the way into the vein, the foot of the vein. And this is just contrast injection within that. We're going to pull that back onto the arterial side, and we're going to try to close that section between the arteries and the vein. And here there is a bifurcation a little bit higher than that, where some of the blood is going to the rest of the nidus, and you can see that how there is a fork at the bottom. So there's contrast going to go into the rest of the nidus, and there's a contrast going to go down beyond that bifurcation into the origin of that vein. And that vein is only draining the fistula. So that foot of the vein does not drain anything else. And because of that, we can sacrifice that portion of the vein along with the artery itself. And the goal is to try to slow that down and come back later on and do more embolization. So this is selective injection from the location where we're going to inject the glue. And again, we're going to inject a little bit higher concentration glue over here. This is really high amount of blood flow. And you can see that the glue is not, it's going to stay immediately closer to the tip. It's just going to go and fill part of that portion of the vein. And because of the higher amount of blood flow, you can see the catheter tip is slowly moving a little bit more distally. So we're taking that foot of the vein, and we are going to ensure that the artery itself is closed, which is the portion between that circular structure and the tip of the microcatheter. And once we do that, we'll pull the microcatheter, and that would be a one session of embolization, for example. And when you do that, you can measure the amount of blood flow. So just putting that small drop of the glue resulted in about 100 cc's drop in the blood flow in that pica. So that is one way of doing it. So you can do that sequentially. And then if you're going to come back and treat this later and do more, take more of that nidus with onyx or with a glue or whatever way you want it, or you want to take the patient to surgery, you can do that. But the goal is, if your goal is to reduce the blood flow, that's one way of doing it. We're going to shift gears a little bit, talking about the pulsatility index. So the pulsatility index is how the pulse changes within one cardiac cycle. And the pulsatility index is an indication of the downstream resistance. So the higher the downstream resistance, the higher the pulsatility index, the more the curve will be really very steep up and down. So can we look at the pulsatility index in the feeder vessels in a way to correlate with venous stenosis, for example, or risk of bleeding? So you can see here that the pulsatility index in the feeder vessel is much lower compared to the contralateral side in this patient with PCA. So when we look at the pulsatility index and the resistivity index between patients who have hemorrhage, extensive venous drainage, stenosis, single vein, or deep location, it doesn't seem that there is a difference between patients who have it versus they don't. So it doesn't seem that the pulsatility index, although it is lower, it did not reach significant. It did not seem that we can use that as a way where we can predict if someone has a venous stenosis, or someone has a deep venous drainage, or someone who has a venous impedance. So that did not correlate well with the angioarchitecture, unfortunately. But what you can see is that you can start with a pulsatility index that is lower than the contralateral side. But when you embolize those AVMs, the pulsatility index increases in those feeder vessels. So when you look at that, the more that you could drop the flow, the more that you can close some of those pedicles, the higher the pulsatility index increases. So there's a relationship of how much the pulsatility index is going to change with how much you reduce on the blood flow. And the question over here is the pulsatility index a predictive of normal pressure breakthrough phenomena, for example? So because the pulsatility index is an indication how much you have a downstream resistance. And that MCA, which feeds the MCA territory, the brain and the AVM, it means that the brain is subjected to flow with a low pulsatility index. So when you shut down that flow to the AVM and the pulsatility index increases in the MCA, does that mean that the perfused brain around it is going to be subjected to a much higher pulsatility index flow? The answer is yes. Does that correlate with the bleeding? We do not know. So this is an example of a patient that has a right temporal AVM, which I decided to embolize, has about 240 cc's, a simple case, which I did treat with Onyx, and you can see here the images on the left is the result at the end of the angiogram. And the image in the middle is a little bit of a delayed capillary phase. What you see here at the end of this image is that around the AVM, there is a little bit of increased perfusion, as if there's a luxury perfusion. And that might indicate that you shifted some of the blood flow to the areas around it. And you can see the CT scan at 0 hours, 6 hours, and 12 hours that the patient bled, although the AVM was completely obliterated. So does that mean that if you shift the blood flow acutely and suddenly to the areas around it, that you end up with bleed? We don't know. Maybe there is a role for this normal pressure breakthrough phenomena if you do aggressive embolizations at once. We're not sure. So this is another example of someone who had a feeder from the MCA, another feeder from the PCA. So about 200 cc's in that AVM. So I embolized the MCA feeder first, came back from the PCA, another session, without compromising the venous outflow first from the first side, and then occlude that. So here, the goal was to do it in a sequential manner so that we have the blood flow reduction gradually. A little bit shift gear talking about the feeder vessel aneurysms. So can we evaluate those things a little bit more? So the whole concept of the feeder vessel aneurysms is that the arteries that are subjected to a high amount of blood flow tends to have a much higher wall shear stress and tends to have a problem with the arterial wall, what ultimately leads to aneurysmal formation. So we can measure the wall shear stress in the feeder vessels and in the contralateral vessels. And we know that the wall shear stress, this is the average cross-sectional wall shear stress, not the one from computational. This is just a cross-section and average over it. So you can see that the ipsilateral arteries that feeds the AVM have a much higher amount of blood flow as compared to the contralateral side. But when you look at patients who have aneurysms versus who do not have aneurysms, the slide on the right side, you can see that the wall shear stress is much higher in the feeder vessels who have aneurysms as compared to the feeder vessels who do not have aneurysms. So it seems that there is some relationship between the two. It seems that high wall shear stress is associated with aneurysm formation. But the question becomes why this is the case. And the answer for that is that if you compare patients who have feeder vessel aneurysms versus not, so the feeder vessel aneurysms is the black line and the one we don't are the dotted line, for the same amount of blood flow, you have a smaller diameter of the artery. So if you subject the artery to high wall shear stress, the artery sometimes will dilate. But if the artery does not dilate and end up with a lower radius, then the wall shear stress becomes exponentially higher because of the power that the radius will carry. So if the radius is a little bit lower, well, this is multiplied multiple times and end up with an exponential increase in the wall shear stress. So it appears that if the arteries that have aneurysms might be the arteries that did not dilate enough, and for the same amount of blood flow, they still have a smaller diameter. So maybe a secondary failure in the dilatation of those arteries. So an example is a feeder aneurysm and an MCA, and it has really very high wall shear stress over there. Another example of someone who has this unresectable AVM and it has a small PCOM aneurysm. So the example on the left side is an older image. The example on the middle is a progressive increase in the size of the aneurysm over time. And this patient has really very high flow in that ICA, subjecting the ICA to a really exceedingly high amount of blood flow that ultimately results in the aneurysm formation and aneurysm growth over time. So if we treat those AVMs, what happened? We drop the amount of blood flow. So before is the black, the dotted line is the after. So once you drop the amount of the blood flow over there, the radius does not really adjust immediately. So you can see that although the arteries will remodel with time, but they don't really remodel very quickly. And if they don't remodel very quickly, then they have really a significantly drop in the wall shear stress. And that is something that we can use to our advantage. Because if the high wall shear stress is the driving force for aneurysm formation, very low wall shear stress might be a driving force for aneurysm regression. And you can see that the wall shear stress, how it will drop after embolization compared to the contralateral side for those particular patients. So that immediately will drop the wall shear stress in the feeder vessels. And you can measure that. So this is an example of an AVM, multiple session embolization, and you can see how the wall shear stress is gradually dropping in that MCA. So reduction in the blood flow will result in reduction in wall shear stress. But if you do that, this is an example where you can see this is PCA aneurysm approximately. And after embolization, before going to the operating room, you can see how the aneurysm is remodeled and shrunken. So those aneurysms that are really very proximally, they can remodel with time. Another example, this is a pica aneurysm that she had bleed. We treated her acutely, closed some of the aneurysms and reduced the blood flow. And you can see 1 week later, the proximal pica aneurysm that one did not bleed and that was not treated immediately have shrunken within the first week. So another example how aneurysms can remodel. But you have aneurysms that are really on a very small feeder vessel. So this is an example of a feeder vessel that's very small from the choroidal plexus. This is pre-embolization, post-embolization, another one from a very small feeder vessel from the lenticular branch, again, that bled pre-embolization of the aneurysm, post-embolization. Cerebellar AVMs also have a high associated of aneurysms, and you can see here, this is the aneurysm that bled pre-embolization and post-embolization. Another example from a pica aneurysm, also that embolized, that bled, get embolized post. This is from a small perforator out of the basilar artery, also has bled, treated with embolization. So you can see that this is the 3 examples, supratentorial that bled, all are on smaller vessels, deeper vessels. This is pre and this is post. 3 examples from the cerebral posterior fossa, also pre-embolization, post-embolization. So what's common between all of those is that they're all smaller vessels. And this is an important thing because in our experience, we know that about 34% of cerebellar AVMs are associated with aneurysms. But we also know that the odds ratio of bleeding from those is also much higher. So cerebellar the AVMs have a higher rate of aneurysm formation, but also has a higher rate of aneurysm bleeding from them. And that might be related to the fact that those aneurysms are located on small vessels subjected to high blood flow with a small diameter. The key issue is that the small diameter, high amount of blood flow that ultimately results in a very high wall shear stress and then bleeding from those aneurysms. So the last segment is about a venous stenosis. So can we investigate this thing a little bit more? We've kind of mentioned that earlier on, is that venous ectasia is associated with higher amount of blood flow. So we kind of establish that. We also know that some of those AVMs have internal hyperplasias within them. And you can see this is how the internal hyperplasia will look within a resected AVM. You can measure the thickest portion of the internal hyperplasia within the nidus, and you can plot the thickest portion of the internal hyperplasia against the blood flow. And we end up with a much higher amount of blood flow in patients who do have intimal hyperplasia. So there is some correlation between the flow and intimal hyperplasia within the resected niduses. So maybe the higher amount of blood flow is the driving force for that. So when we look at venous stenosis, what are the risk factors? In our group of patients with AVMs, you can see that hypertension, diabetes, and hyperlipidemia are more common in patients with venous stenosis. So now we're thinking about venous stenosis and venous hyperplasia as a dynamic process. Same thing, we look at it as we look at the arterial system. It is not something that we're born with. This is something that is affected by other risk factors. So we have to think about it in a dynamic process, an inflammatory thing. And you can see that the risk of the venous stenosis also increase with age. So patients who have or more than the 50 years of age have a much higher rate of venous stenosis as compared to someone who's younger. So maybe as we wait enough and we get older, we subject those to a higher amount of blood flow over a long period of time. Maybe we end up with a higher rate of venous stenosis. And the venous stenosis, you can evaluate that with the transient time on angiography. Patients who have venous stenosis tends to have the wave of the contrast at the trans in that vein, proximal to the vein, becomes really very narrow because you're squeezing the blood flow under high pressure, relatively high pressure, before it exits the stenosis. And when you can see that those transient times in venous stenosis is much shorter than the patients who have no venous stenosis, and that also correlates with the bleed. But is it the venous stenosis that caused those short transient times, or is it the hemorrhage that caused that? Also, we do not know. It's unsure from this study. You can see that the location of the venous stenosis in those 6 patients are all far from the nidus. They're not in the nidus itself. They're all closer to the sinus. So that's an observation. And when you can see that about 80% of the venous stenosis is within 2 centimeters from the junction of the sinus. And when you look at the ratio of the draining vein to the sinus, as the ratio increases, meaning that the veins becomes larger as compared to the sinus, the draining sinus, then the risk of venous stenosis becomes much higher. So there is some anatomical / hemodynamic relationship between the sinus and between the draining vein that might be the reason for the venous stenosis. So we took this example, this unpublished data. So the image on the left side is someone who has venous stenosis, and the artery, the angiogram is the blue color, but we asked the guys to simulate it without the stenosis. So we remove the stenosis, and the image on the right side running the simulation. And you can see that the areas where the venous stenosis did develop has a really very low wall shear stress. So this is by computational modeling, and you can see the blue color between the vein and the draining sinus on the image on the right side. So maybe the low wall shear stress and that junction itself might be the reason for the venous stenosis. So we talk about the venous stenosis and we talk about the role of inflammation in intimal hyperplasia, but is there a role for inflammation? And the question is, if you want to answer that question, is to do vessel wall imaging. So this is vessel wall imaging on the draining veins in those patients. So this example before is pre, and after contrast is below. You can see the enhancement in the draining veins. Another example also pre at the top, post at the bottom. You can see the enhancement in the draining vein. And this is a patient who had this AVM that we did not treat, and he came back later on. Look at the FLAIR image. There's no FLAIR image changes initially. Come back 6 months later, and now he has significant FLAIR changes. And when you look at the angiogram, he did develop a new venous stenosis that resulted in a bit of a drop even in the blood flow in this AVM. So this is an example where a venous stenosis did develop and did result in venous hypertension around it with a clinical presentation of a seizure. And you can see here there is enhancement in the draining vein in this particular patient around that area of the stenosis. So when we look at the vessel wall imaging and the blood flow, you can see that there is a near positive relationship because the sample size was small. So the higher amount of blood flow is not statistically significant, but is is near significant relationship to the presence of the venous stenosis. So that's something that needs to be explored a little bit more in the future to see if the higher amount of blood flow is the driving force for venous stenosis. In relationship to hemodynamic stresses and inflammation, so the same concept of the CFD that we do on the arterial system and in the aneurysms, can we do that on the venous system? So here we can see that we are extracting the draining veins along with the sinuses, and we are using the flow of the AVM as an input function. And we have vessel wall imaging that we have from MRI. So we extracted the vessel wall imaging from the MRI and we superimposed it on the 3D model. And you can see the images here showing you the enhancement superimposed on the 3D model. So, and then you could see that this is the area of enhancement that is on the larger draining veins, multiple draining veins, and then you run the simulation at the same time. So now you have a simulation map, which is the image on the left, and then on the middle, you have the superimposed velocity, and on top of that, the purple color is where the enhancement is. So you have an enhancement by MRI, and you have a simulation. And when you correlate those two together, you end up with some significant result. And it seems that there's a significant decrease in the average wall shear stress and in the almost significant decrease in the velocities in the areas that have enhancement. So it kind of takes you back to the arterial system where we know that the wall shear stress does play a role in inflammation on the arterial system, but it seems that also have some role on the venous system as well. So this is just an illustration to show you the level of enhancement that kind of corresponds to the low average wall shear stress, which is the blue color on that vein. So we started by talking about Spätzler grading and from Aruba, and we said that the results were not good. Well, that's not 100% true. There's a new data that came out from the MVQI, and you can see that the outcome of those patients in what's called the Aruba eligible patients are much better if you select your patients appropriately. If you do more patients with microsurgery as compared to the Aruba trial. In the Aruba trial, only 5 patients have surgery, while in this study, you can see that there is a big portion, about 50 patients have surgeries. But there's also patients with embolizations and surgery as well. So when you do all of that stuff, then the death or stroke rate drops significantly. So it's about 8.7%. So it seems that there is a lot of benefit for selective approaches that we're doing. But we're still not really there. From that trial, from that kind of registry, you can see that still embolization alone carries a little bit a higher complication rate as compared to microsurgery plus embolization. So we have to kind of optimize what we do a little bit better. And how do our results kind of compare with that? Because our approach has been blood flow reduction and going for surgery. And you can see that our permanent deficit major complications only 3.8%. So if you utilize an approach, whatever works for you, that results in a really low complication rate, then that should be the way to go. But I think we're going to need to have a little bit better understanding about the entire pathophysiology and mechanism of AVM so we can tailor this treatment in a much better and safe way. So to conclude, we've kind of talked about the higher amount of blood flow in some patients. We talk about the sequential reduction of the blood flow in some patients. And we talk about the hemodynamic stresses that are on the arterial system that leads to aneurysm formation, on the venous system that results in inflammation and in development of venous stenosis. And these are my references, and thank you very much.
Perfect. Thank you so much for this tour de force of AVMs. we have a few questions. One is, for the general audience who's with us who don't do this on a day in, day out, obviously, and at the same level as you do, you've clearly spent a lot of your career thinking about AVMs. And then you have this big shift. However we think about it, it is still a big shift that when Aruba came out, and there like in the general practitioner group world, what would your advice be to these people who, they're seeing this young person or this whatever person in the ED for something unrelated. They see this incidental AVM, or their primary care is getting these patients who have these incidental AVMs. They're small, they don't know what to do about them. Patient is asymptomatic. What do you tell them about, okay, when is a red flag, or do you say, okay, always send it to somebody? Because there's this trend now of saying we don't need to treat those, just watch them.
So what do we learn from Aruba? We learned two things. We learned that an approach that is not tailored toward cure is not a good approach. So what I got out of Aruba is that if you treat AVMs and cure is not an outcome, definitive outcome, then you end up with problems. But we also learned from Aruba is that the natural history is about 5% rate of bleed per year. So it's not 1 to 2%. It's kind of, we usually kind of say it's between 2 to 4%. Well, it's about 5% per year. So every single patient who's diagnosed with an AVM should be evaluated in a multidisciplinary neurovascular team. And the patient should be looked at and evaluated, and multiple modality images should be done, including functional MRI, tractography, all of that stuff. And the discussion should be, can we treat this AVM to cure or not? That's the question. If we can treat this AVM to cure with a low deficit, then we will do that. And if we can do that endovascularly, safely, fine. If we want to do that surgically, absolutely. If you want to do it both combined endosurgery, also perfect. If you want to do radiosurgery, also perfect. But I think in the Aruba, not everybody was cured, right? Not everybody was cured, and there was a lot of complications that happens over there. So, but if you do a tailored approach and you have a multidisciplinary team that looks at that, and you look at every single patient, and you say, okay, this is our map, this is what we're going to do, and the goal is for cure, then everybody should be treated if they meet those criteria.
So to follow up on that, so in your approach, if you see an AVM, unless you think there's a cure, you do not do you still attempt something at this AVM, or if you can't cure it, you just watch it?
If we can't cure it, we only treat things that have bled or things that could bleed, specifically aneurysms.
Okay.
So yeah.
Oh, sorry. So going to the bleeds, have you been able, like, based on all your computational models and flow models, have you been able to figure out, like, what is the rupture point, or have you noticed, like, what areas, what makes an area a higher risk of rupture point, or are you able to define that before embolizing and maybe attacking that point first versus leaving it to second or third embolization stage?
So if you find an intrarenal aneurysm, that is presumably the source of the bleed, and then that's the thing that we tackle usually. But you're not going to find that in every single patient, right? So then you do an angiogram, you don't find that, then you don't embolize anything acutely. If you find a feeder vessel aneurysm and you feel that's the source of the bleed, then you can treat that. What we have done in very few cases, we have done palliative treatment. So we have some few patients who progressively become weak with time from steel. Very few patients, very large AVMs, and there's really very large shunting through them. So we can just go and close those shunts on the arterial side just to decrease the steel so that the brain around it will get more blood supply. That is on really an exceptional cases and rare cases. But the goal is to cure the AVM, because if you partially treat an AVM, then the natural history might even be worse. So you're better off not treating that rather than do a partial treatment. And if it's not resectable and it's really very large for it to be embolized for cure, you can do those new fractionated radiation. It doesn't really work very well, but it allows it to shrink. And some of those might shrink enough where they could be surgically resectable. So you're gonna need to kind of look at the whole picture together. But definitely all patients should be evaluated in a multidisciplinary cerebrovascular center. And if that center decide they don't want to have treatment, that's good. But a lot of majority of them, they will end up having treatment because the natural history is not benign,
Right.
especially for
Right.
someone who's young.
Right. When you're deciding, you're embolizing, and I've heard you talk about these before as well. Like when you embolize specifically the fistulous points, whether just very little bit of onyx or NBCA or whatever it might be, when you're injecting those little, they just and then it leads to a significant decrease in flow because you're hitting the fistulous point. Before you get to that embolization, are you able to measure how much flow you're going to decrease, or is it just observational? Like I know this is going to decrease flow significantly, and I measure it post-op to see how much I did.
So there's no way that you can predict how much there is within each fistulas pre-op because all of those flow measurements is on the arterial system proximally. They're not within the nidus itself. And all of those modeling is not within the nidus itself. You cannot do that. It's really very, very difficult to do that. So you know what's the amount of blood flow. So let's say you look at this AVM, you say it's about 600 cc's per minute. So, and you look at the angiogram, and an angiogram, you see this very large artery that comes in, immediately becomes a vein, right? So you know that there's an internal fistula. But we know retrospectively that if you embolize internal fistula, you resulted in about 100 cc's per minute of blood flow reduction. What I'm trying to make here, the point is that if you go and take care of only internal fistula that day, that is sufficient. That is my point. Is that some people they got in there and they got this AVM that's 3 centimeter, and putting a small amount of liquid embolic agent into that fistula, closing that small segment, doesn't look much. It doesn't look much on the volume perspective, but on the flow perspective, it looks a lot. And if you do close that fistula and you cut the blood flow by 100 cc's, that is sufficient because we're still not sure why some of those AVM bleeds when you embolize them for cure, right? We're still not sure why if you close a big portion of the AVM will bleed in the next few days. So we're not really sure what happens. So there is an element of that might be that redistribution of the blood flow, bleeding around the AVM from the brain. So we're not really sure because you could like be exclusively on the arterial system and not compromise the veins, and you still end up with a bleed.
Yeah. Well, we're coming to the end of the hour. Thank you very much, Dr. Alaraj, for this thought-provoking presentation, and for everybody, I hope you enjoyed this grand rounds as much as I did. Again,
right.
Thank you again. Have a good day.
Thank you very much. A great pleasure for meeting you guys all. Have a wonderful day.